All right. Hello, everyone. My name is Craig Struble. I'm a consultant at CERC. Welcome to the series entitled Supporting Your Child's Health and Well-Being During the School Year, brought to you by the Connecticut State Department of Education. Tonight is part 2, Preparing Your Family for Cold and Flu Season. Before we get started, I'd like to go over some of our Zoom features, and you might be familiar with a lot of them, but there are a few new ones. The first feature is sign language interpretation. You may have already noticed this notice popping up letting you know that sign language interpretation is available. If you would like this option, select the interpretation button on your toolbar. If you do not see this button, you may need to select the More button on your toolbar. After selecting the interpretation button, a menu will pop up. Then simply select American Sign Language, and you will then get a pop-up window with our sign language interpreter. The next feature is the closed captions and caption translation. If you would like the captions on, select the Show Captions button. If you would like to change the language of the caption, select the small arrow in the upper right corner of the button. When the menu appears, toggle Translation on, then choose your speaking language and the caption language that you would like. Next, we have our chat button. Please use this for sharing information, providing reactions, or also for mentioning any technical difficulties, and we will monitor the chat and do our best to help you out in that situation. However, please do not use the chat for any questions that you have for our presenters. Those can sometimes get lost in the mix. Instead, for that, we have the Q&A button. When you select this button, a window will pop up, and you can use it to ask our presenter specific content-related questions. And if you see that you have the same question as someone else, you can give it a thumbs up and upvote it. Finally, we have the React button. Select this button to use emojis to show your reactions throughout the presentation. And that's it for Zoom features. So now to get us started, I'd like to hand it off to Chloanne Bobrowski, Education Manager at Division of School Health and Family Support Services.
Welcome, everyone, and thank you for joining us tonight for an engaging and informative webinar on the topic of respiratory health and wellness. Before I begin my introductions for our panelists tonight, I would like to remind everyone to please refrain from putting any personal or confidential into the chat. This webinar is being recorded and transcriptions are also being recorded, so we'd like to maintain your confidentiality. So I am pleased to make the following introductions for our panelists tonight. First, we have Dr. Sten Vermond. He serves as professor in pediatrics at the Yale School of Medicine. Dr. Vermond was the former dean of the Yale School of Public Health, and he's also a member of the U.S. National Academy of Medicine and is president of the Connecticut Academy of Science and Engineering. Dr. Vermond is an internationally renowned public health expert and was appointed as president for Global Virus Network. This network works to improve the health of people worldwide, calling attention to research and training needs, and assists countries to prepare and respond to viral threats, outbreaks, epidemics, and pandemics worldwide. When I called Dr. Vermond to request his presence here tonight, he was actually at a conference in South Africa, but he took my call, and I'm really appreciative that he did, and he's here with us tonight. In addition, he enjoys tennis and jogging and is married with 2 grown sons. With Dr. Vermond, he brings his associate, Dr. Marie Bro, who is an assistant professor in the Department of Population Health and the Institute for Excellence in Health Equity at the New York University Grossman School of Medicine. Originally from Tennessee, she trained in medical anthropology and public health at the University of Connecticut and did postdoctoral training at the Yale School of Public Health. Her work research focuses on child, adolescent, and young adult health. Please join me in welcoming our presenters tonight, and I'll now turn this portion of the webinar over to Dr. Vermond and Dr. Bro.
Thank you so much for the gracious introduction. I want to ask a question. Do you see my slides? Yes?
Uh, I don't think so.
You
Oh,
don't think so?
well, I see your screen, but not a slide yet.
You don't see the slides. Okay, that means I may have. Do you see them now?
Here, yes.
Yes.
Now you see them. Brilliant. All right. And we
Oh, but it's
probably.
presenter's view,
Yes,
Stan.
I knew it. I knew
Sorry.
it. Hold on. Okay, that should do the trick. How is that?
Perfect.
Okay, excellent. Thank you so much. Um, very happy to be with you this evening and to talk about this salient topic. I remember vividly when my children were small, I was as concerned as some of the parents on the call and grandparents who joined us today. So, just to remind you that infectious diseases are not as common as they used to be, thanks to improved housing, improved nutrition, vaccines, antibiotics, and the like. We've had a substantial diminution in the death rate for infectious diseases. This was the pandemic influenza of 1918 and 1919. Here we had first use of penicillin, the Salk vaccine for polio, and the slight rise in mortality from infectious diseases after in the 1980s and 1990s was largely due to HIV. Respiratory virus season at school is a good friend of ours. We see it every year. There are close quarters, whether on a school bus or in a classroom, and the children are mixing. They're friends. They're hanging out together, and that's wonderful. We have a lot of oversight in our schools, trying to keep children safe. We try to get them to adhere to practices like washing hands, and we have an obligation for education, and anything we can do to mitigate or blunt the impact of respiratory viruses, we try to do. So this word mitigation, how do we reduce risk, is a theme for this evening's presentation. Now, this is the millions of upper respiratory tract infections by age and year. And you can see that the number of episodes is in the thousands of millions, and tremendous burden around the globe. And when one looks at this is the absolute number of episodes, and then you look at the incidence rate, looking at the cases per 100,000 population by age and year, you can see how the young children are disproportionately affected. Now, you might say, well, why are there not very many cases here? This is only a 7-day period. This is only another 2 weeks. So, these are 5-year blocks. So this is a little bit artificial. This is what you really want to look at. And you can see that it's really our under 10 years of age group that is most heavily afflicted by upper respiratory infections. Now, we learned a lot in COVID-19, and we learned that shuttered classrooms hurt vulnerable students the most. So we're not keen to close classrooms because of respiratory threats. COVID was a bit of an emergency, but we hope that won't be repeated. And we believe that schools can be run safely even in the pandemic of COVID or emergence of other respiratory viruses, as long as we have rigorous and disciplined structure and cooperation within the school environment. Investments are essential. We have to have the hand washing. We have to have the appropriate materials for cleaning schools, and we have to have investments for vaccines, and we have to make compromises. We have to get a vaccine for our child, not only to protect them, but to protect others. So now that we have vaccines, this was a major achievement from Operation Warp Speed, which was a public-private partnership in 2020 which had broad bipartisan support. And vaccines are really the game changer in the COVID-19 pandemic. But you'll see that many parents and even some pediatricians are not aggressively vaccinating children. So let me start by telling you how vaccines work. The mRNA, the messenger RNA, which is genetic material that we use to create proteins, we now know how to make vaccines from this material. They don't use live virus and they don't affect our DNA at all. What they do is bring instructions to our cells to make a harmless piece of what's called the spike protein, which is found on the surface of the COVID-19 virus. And our immune systems, if they see this spike protein, they develop antibodies. And so if the real virus shows up, not sort of the spike protein alone, but the real virus, which has spike proteins, then our body can produce antibodies very, very quickly because our immune systems immediately recognize the protein doesn't belong. We've seen this protein before and we didn't like it and we mounted an immune response. That was the vaccine. Now we see the real organism and we still don't like it and we can produce a vaccine very quickly because our immune systems have a lot of memory. Now, vaccines have really helped all but eradicate a whole host of diseases. We've reduced measles by 99%, pertussis, which is also known as whooping cough, by 99%. We've reduced mumps by more than 99%. We've reduced rubella, used to have 50,000 cases, now there are only 3, by more than 95%. We've completely wiped out smallpox, and we only have a diphtheria case every few years. And wild-type polio has also been wiped out. So from 500,000 cases a year to 9 cases a year, 200 cases, 1,000 cases a year to 1,600. So it's amazing what's happened in the 20th and early 21st century with the use of vaccines in our children. We have been able to almost wipe out these terrible diseases. Some of them are deadly. Now, these are the vaccines recommended by the FDA that evaluates the efficacy and the safety. Do these vaccines work and are they safe? And the CDC, which is also looking at efficacy and safety, but they're doing cost-benefit analysis and figuring out whether any harms from a vaccine are balanced by the good. Now, in children, we would like to give influenza vaccine or flu vaccine to all children 6 months of age or older. We'd also like to vaccinate pregnant women to protect the women, and also that helps protect their newborns. There's some immunity that crosses the placenta and gets into the newborn baby and protects the newborn baby from influenza. We would like to give updated COVID-19 boosters to all children over the age of 6 months. And of course, the routine vaccines, such as diphtheria, tetanus, and acellular pertussis, measles, mumps, and rubella, and varicella, which is another word for chickenpox, and several others if they haven't already been obtained in infancy. In adolescence, we want all these vaccines also to go to the adolescents, but also human papillomavirus to prevent cancer and meningococcal serotype vaccine to prevent meningococcemia, which is a brain disease. So whether you have small children, school-age children, or adolescents, let your pediatrician know that you want to bring them in for their vaccine updates. Now, for adults, we want flu vaccine for all adults, and they offer higher doses for persons over the age of 65 or with immunosuppression, because those of us my age, over the 65, need a higher dose because our immune systems are not quite as vigorous as those of you who are younger. We need updated COVID-19 boosters because there's now a newly circulating Omicron variant, is what we called, and the new booster is specifically targeting that variant. So even if you've been vaccinated in the past and your children have been vaccinated, it'd be very good to get the booster because it's much more specific and protecting against the circulating COVID-19 virus strain that's happening right now. We want to give all adults the tetanus, diphtheria, and acellular pertussis at least once in adulthood to boost your childhood vaccines. And if you're over the age of 65 or a bit younger and immunosuppressed or in a nursing home, 60 to 74, we want to give you the respiratory syncytial virus vaccine. This is a huge breakthrough and reducing mortality in our elderly. And of course, the shingles vaccine doesn't have anything to do with respiratory disease. Shingles is a disease of the nervous system and the skin. So if you're 50 or older, or if you're 19 and older, if you're immunosuppressed, we want to give you a shingles vaccine. And shingles is a nasty disease. So whether children or adults, we're very excited about the modern era of vaccines and the excellent vaccines. However, there is a tsunami of negative vaccine coverage. This is a cartoon from a New York City newspaper in 1930. And this was when there was a smallpox outbreak in New York City, and they were trying to get everybody vaccinated to stop the smallpox. And here you have an anti-vaccinationist, blinded by prejudice, a faddist, Mr. Careless, anti-everything, and they're marching over the cliff of misinformation. And people like Robert F. Kennedy Jr., Robert Mendelsohn was a doctor, Andrew Wakefield was a doctor whose medical license was removed in England, where he was from. Jenny McCarthy is a celebrity actress. And these people and others are writing all sorts of nonsense about vaccines that simply isn't true. And I can tell you as a pediatrician, public health expert, it's not true. Take a look at what happened in COVID. This was US death rate by vaccine status after the vaccine became available. And when we had a surge of COVID-19 in the late summer of 2021, these were the mortality rates of the unvaccinated, and these were the mortality rates of the fully vaccinated. Now, take a look at the hospitalizations, the same story, a massive rise of hospitalizations. Now, vaccines do a better job blunting the severity of infection. They don't always protect you from infection. In fact, they usually don't protect you from infection, but they protect you from severe consequences of infection. And that's what people don't realize. They say, well, I got a COVID vaccine, but I still got COVID. And I say, did you end up in the hospital? Did you you're talking to me, so you didn't die. So the point is that we blunt the severity of these diseases with vaccines. Here is our data early in 2021 from the state of Kentucky. And more than 95% of the 443 people under the age of 60 who died of COVID-19 were unvaccinated. Of these 444 people, only 21 had been inoculated with the vaccine. So hugely beneficial with efficacy rates of 90% and more. Now, why should we vaccinate children and adolescents for COVID-19? First of all, they're going to miss days of school if they get this condition. You may have to do some isolation and quarantine. That's disruptive. From 2020 to mid-2023, there were 776 deaths in children under the age of 5. I've heard people say on television, children don't die of COVID. Wrong. They can die of COVID. Not as common as in the elderly, of course. We even had more than 1,000 deaths in 5 to 18-year-olds. And that was more than 1%, about 1.5% of all the deaths of children in those 3.5 years were from COVID-19. So if anybody tells you, I'm not going to get a vaccine for my child because kids don't get COVID, they don't die of COVID, they're wrong. We also have a condition called multisystem inflammatory syndrome in children. We sometimes nickname it MISC. And long COVID can also happen in children. And these are vaccine preventable complications. There were almost 10,000 MISC cases and 80 MISC deaths as of September 24. So there's a risk to vulnerable children, like immunosuppressed children or unvaccinated children, and to adults, especially the older of us, if we don't maintain herd immunity. That means enough people are immune so you don't have transmission. And we have herd immunity now, but if people don't get vaccine boosters, we may lose that and we may have a surge of COVID-19 again. And there's so much vaccine hesitancy in adults that those of us who want to protect our children and also protect society, we should get vaccinated, our children should get vaccinated. It also has the promise of defending against future highly infectious or pathogenic variants in the future, because the reality is that we don't know what's around the corner. And even if we have partial immunity to a new strain, we'll be much better off. Now, this MISC is a rare but serious illness. It affects multiple organs, the eyes, the brain, lungs, heart, kidneys, gastrointestinal tract, and skin. And most cases of MISC occurred in unvaccinated children and children whose immunity from prior vaccination had declined over time. And the CDC is urging up-to-date COVID-19 vaccination to protect against complications like MISC and like long COVID in children. Now, to judge the risk benefits, what are the risks of vaccinating children and adolescents against COVID-19? Well, adults and children may have transient side effects from the vaccine: pain, redness, swelling, tiredness, headache, muscle pain, chills, fever, nausea. Often, a Tylenol can be helpful, and an ice pack to the injection site. And typically, the next day, you feel better. Serious side effects are rare, but may occur. There's something called anaphylaxis, which is an allergic reaction, and that happens in about one case, about half a case, one case per 200,000 doses, or half a case per 100,000, or you can say 5 cases per million doses. Now, that's why they ask you to wait for about 15 minutes to half an hour after you got the dose, because if you do have this allergic reaction, your healthcare provider gives you a shot and you're fine, an epinephrine shot. So it's really easy to treat. Now, more worrisome is something called myocarditis, which is an inflammation of the heart muscle, and pericarditis, inflammation of the outer lining of the heart. So nearly all patients with myocarditis or pericarditis respond well to medicine and rest and feel better quickly. So this is mild pericarditis or myocarditis. It is not the bad kind. And the pooled incidence is about 63 per 100,000 vaccinees, and pericarditis is only 7 per 100,000 vaccinees. It's more commonly observed in adolescent males and after the second dose of Pfizer. We don't know why the Pfizer causes more of this than the Moderna. We're not sure why. Now, the adolescent males, if you want to boost them with a different kind of vaccine that's not an mRNA vaccine, that's perfectly reasonable, and you can reduce the risk of myocarditis and pericarditis. Now, it's still very rare. There was a European study that said that there were 2.7 excess cases of myocarditis for every 100,000 vaccinated individuals versus unvaccinated. So it wasn't very many excess cases. Now take a look at this. This is myocarditis in 1 million subjects. For COVID-19, you're going to get 1,400 myocarditis cases in 1 million subjects. With the vaccine, you're going to get 50. So, I mean, I would rather take the vaccine and not get COVID rather than risk COVID. And so that's the point I wanted to make here. And I think I'll move on because I want to get to the next topic. So the protective effect from a systematic review against long COVID, they took a look at almost more than 500,000 unvaccinated and 84,000 vaccinated individuals, but before they got their infection. And they found in 6 observational studies about 8,000 long COVID patients who received vaccination after SARS, that the 2-dose vaccination lowered the risk of long COVID by 36%, and 38% protection against persistent fatigue, and 50% protection against later pulmonary disorders. So not only are you not going to get as sick from COVID-19, not only are you going to protect your children from MISC, you're also going to protect them from long COVID. Now, there is a new booster vaccine, and the Kaiser Family Foundation has the COVID-19 vaccine monitor, and they ask people in surveys Have you already gotten it? Will you get it soon? Are you trying to wait and see what happens? Are you going to get it only if it's required, or are you going to definitely not get it? And this is what they found from 2020 to 2022, that the proportion who definitely don't want the vaccine hasn't changed much. So there's about 12% of the population that doesn't want to get the vaccine no matter what. Most people have already gotten the vaccine by now. And this plateau where we can't get to 100% is commonly seen in public health, either because it's hard to access certain subset of people, or there are people who simply don't want to get the vaccine no matter how good it is. Now, the funny thing about this, it's become kind of politicized, which is very disappointing to somebody like me, because I want to see everybody rowing the public health oars in the same direction. I want to see everybody enthusiastic about what we can do to prevent COVID. But if the older people who are Democrats, college graduates, African Americans, higher income, suburban women, they're less likely to be hostile, and they're more likely to get the vaccine. More likely to be hostile to the vaccine are uninsured persons who are younger, rural residents, middle-aged persons, 30 to 40, 49, Republicans, persons without a college degree, independents, again, younger persons. So that's unfortunate that somehow this has become politicized. Now, here are a percent of parents who say their children have been received at least one dose, and it's only 50% of parents of adolescents and only 39% of school-age children and a mere 21% of the under fives. And here is whether you are going to give them the new vaccine, the current new vaccine against Omicron. And here you had only about 13% who definitely were going to get it, about 25% who were probably going to get it, and a huge proportion. This is very unique. You know, I as a practicing pediatrician for a number of years, parents wanted to protect their children. They wanted to give them the vaccines that would protect them. And for some reason, people are afraid of COVID. And this is some of the reasons. I think it's too new. I'm worried about long-term side effects. It hasn't been around long enough. I want to see if there are any side effects, too much uncertainty in kids. I don't trust the FDA. People get COVID anyway. It's potentially harmful. We've not seen anybody get COVID, and COVID doesn't affect the kids very much. I can argue against every one of these statements, and I disagree with all of them. I think that COVID is a terrible disease, and it can affect a small number of children very, very severely. And we use a lot of vaccines to protect a small number of children from severe disease. So why exclude COVID-19? Now, we've learned that in real world conditions, we have high efficacy if we can have high coverage. We know that school air quality is important, masks if we have outbreaks, physical distancing if we have outbreaks. We want to cleanse services, keep restrooms clean, hand washing. We know the COVID Omicron is circulating. And what does this say about public spaces like schools, risk for the aged, risk for the unvaccinated? We don't think that we're going to have a big outbreak for COVID-19 like we've had in past years. So schools should stay open. The more children who are vaccinated, the fewer children are going to get sick. Risk for the aged remains high, and we definitely want to get all of our older citizens boosted with the vaccine. Risk for the unvaccinated, it remains high, and the only people who are dying these days are overwhelmingly unvaccinated people or vaccinated people who have underlying serious medical conditions. So vaccine is hugely protective. We like to keep the air clean. This is a low-cost air purifier that was designed by our colleague Crystal Pollitt. There is, you can go to YSPH, Yale School of Public Health, and just type school guidance COVID, and you'll get to this website right away. And you can spend $60 on a window fan, a tape with blue tape, the kind that the painters use. and just tape the filter to the back of the fan and filter air in your own homes. Keep in mind too that we want to keep children in school, and I'd like to turn it over to my colleague, Dr. Marie Bro, to say a few words about mental health issues in this era of respiratory concern. Marie?
Thanks, Don. And thanks for having me tonight. So we know that a lot of students missed school due to COVID. And for some students, lockdowns were more localized, limited to a semester, maybe 2 semesters, whereas other students were out of school for over a year and a half. And we're still unpacking a lot of the implications, particularly for social, emotional, and mental health for youth as a result of COVID-19 school closures and lockdowns. Although we're still trying to figure this out and the long-term effects, what we found is that there are a number of protective factors. Children and adolescents who tended to do better during COVID school closures were those who were able to get an average of 30 minutes or more of physical activity a day. So getting out, moving, being active was very helpful for their mental and emotional health and well-being. Having siblings, even when they drive you crazy, is also very helpful. It's another source of social support and socialization in the home. Children and adolescents living in predictable home environments. Anytime youth had consistent routines, consistent bedtime, and some sort of structure to their day, that was also highly protective of mental health. Feeling socially supported, both at the parent, guardian, family level, as well as at the youth level, is very helpful. Anytime we can help, particularly adolescents, feel like they're staying socially connected to their peers, that is protective of mental health. And interestingly, COVID-19 prevention adherence. So children and adolescents who were able to engage in COVID-19 prevention activities. And for adolescents, there's also some evidence to suggest that youth who were actively involved in COVID mitigation efforts, promoting vaccination, providing support to their peers during COVID and during school closures, that was also really helpful for children's and adolescents' mental health. Risk factors for poor mental health. Those youth who had mental illness and neurodivergent or neurodevelopmentally disabled youth, they tended to fare worse in terms of anxiety and depression in the context of COVID. Those who'd had early life stresses or challenges, and those with just kind of higher baseline fear tended to do worse. Older students, particularly those high school juniors and seniors, really struggled, were anxious about how they were going to keep up with their coursework and their education. Adolescent girls and young women also tended to have poor mental health compared to their male peers. And then virtual learning could also be pretty stressful for youth. And then kind of thinking about the family context, again, loss of childcare, changes in insurance status, and food insecurity, as well as economic challenges, tended to put a lot of strain on parents and caregivers, which then was reflected in children's mental health and emotional well-being as well. And then we've seen increases in mental health related emergency room visits for youth related to suicidal ideation, sleep disruption, COVID fear, anxiety, depressive symptoms have all become more common in the context of COVID and school closures. Among younger children, kind of the elementary school children, we've also seen an increase in clinginess and some behavioral issues. And then parents kind of self-report of the impact of COVID on their mental health. A lot of parents also experienced challenges adapting to virtual learning environments and dealing with their children's needs. And then we know that not all schools, not all communities are able to access virtual learning equitably or easily. And so a lot of children in disadvantaged schools and communities, and then children who have special education needs, their learning really kind of fell behind at this time. Next slide, please. Oh, I think this is Stan's.
All righty. We're all done, and we're going to be taking your questions in a moment. But just a reminder, vaccinate, vaccinate, vaccinate. This has been the most powerful tool for infectious disease control for respiratory diseases in the 20th and 21st century, and nothing's changed. COVID-19 causes vastly more harm than do vaccines. And it's overwhelming logic, in my view, that we should vaccinate children and adults equally. Please remember to test if COVID-19 is a possibility. The home tests are still out there. And we won't be masking unless there's a huge surge in the peak season. We don't think it'll be necessary. But if we do have a huge surge and it's going to help protect our children and our vulnerable elderly, it's a possibility in the future. We want to watch out for our children's mental health and their socialization, as Dr. Breaux has just articulated. We want to rebuild societal and consumer confidence in public health measures, because for some reason, even though I think that the public health community was heroic in helping reduce COVID-19, somehow we've gotten a bad reputation. And people who have conspiracy theories think that somehow we're in cahoots with the pharma industry and all sorts of strange hypotheses. So we want to anticipate future pandemics and prepare. So please think about the flu vaccine and the COVID vaccine, and update other vaccines for your children and for yourselves. Keep in mind the grandparents especially. And we really want to enable people to stay safe and healthy. So happy to take your questions. I'm looking at the Q&A. I don't see any questions yet.
No, I don't, but I would like to make a comment just from since I am a manager that supports school health. The Department of Education did send out a letter, which I distributed to the school districts, that they are offering free test kits to school districts.
Wonderful.
School districts, and this is to make sure that they stock the nurse's office, stock the main office in the school, to be able to provide to families in the communities, to put in the kids' backpacks. So districts have had the link to order these free of charge.
Well, that's great news, because they're not cheap in the pharmacy. And I know that the federal government was providing them for a while, but it's great that the Department of Education is putting our tax dollars to work and helping keeping our kids
It is
safe.
a federal program. It's not
Oh,
from
it is a
Connecticut
federal
Department.
program.
Yeah, it's
Okay,
from the
well, then
Federal Department of
then
Education.
those tax dollars, one way or the other.
Yes, but it is, they will be available. The ordering, I think, opened up a couple of weeks ago. So they'll be able to get the free tests.
That's
Which
great.
I think
And,
is
a
helpful to
shout
families.
out to all of our school nurses and personnel who are working with our kids every day in school. I do see a question now, a couple of questions. I'm not quite sure which one came first, so forgive me. We often hear that COVID booster missed and doesn't actually work on the new variant. Is this not the case with the newest booster? Actually, that's incorrect. what happens is that this RNA virus is very clever at mutating. So the original Omicron variant was what the new booster was built on, and it was developed, took many months, and finally was released. By then, new Omicron variants had emerged and became prominent. But the really good news is that the vaccine generates an immune response that also works against these new circulating Omicron. That's why they haven't developed yet a new one, because they don't need to. So the Omicron booster vaccine is working against all the Omicron variants so far. Now, I'm not saying that next year we won't need a new vaccine, but so far this vaccine is working very well. Thank you for that excellent question. Now, does mental health effects of COVID-19 have to be demonstrated in a child all at once in order to call it mental health? Well, that's an interesting question, Marie. I'm going to let you think about that one. I would say
Sure.
mental health is something that we deal with every day in our own lives, in our children's lives. So I think Marie's point was, other than the normal challenges that we face, what did COVID-19 add to those normal challenges? Go ahead, Marie.
Yeah, and I think I think it's a great question. I think one other thing that we're realizing is that, mental health is kind of a long-term continuing thing, and particularly for youth who experience trauma during COVID-19. It will take time to see some of the PTSD and kind of longer term mental health effects from COVID develop. And so that's why we say to definitely, continue to keep an eye on kids and their friends, because even at this point and with, all of the progress that we've made, there could still be lingering mental health effects from COVID, for sure.
Excellent, thank you. Now, there's a question about strep. So streptococcus is a bacterial infection, not a virus like influenza or COVID-19. So that makes it a little easier to treat. And we can treat streptococcus with antibiotics. Antibiotics don't work for viruses. You have to have very special drugs, antiviral drugs, or monoclonal antibodies to treat viruses. But we can use antibiotics. Now, the problem with strep is it's often overdiagnosed. There are lots of viral diseases of the upper respiratory tract and the throat that can cause a little bit of fever, can cause a sore throat, but they are not streptococcus. So what's helpful is to go to your healthcare provider and actually get a culture. And we even have rapid strep tests that can give you an answer even without a culture, just with a rapid test, looking for a particular fragment that indicates strep infection. And we'd like to treat the children who have strep with antibiotics and not treat the children who don't have strep and they have similar symptoms but from a virus. Now, because the viruses go away on their own, the body will fight them off. But strep is problematic and has side effects and has complications. So we would like to use antibiotics against strep. So if your child has a sore throat, typically fever, you look in the throat and it looks very red, more than usual, maybe even looks like there's some pus on the tonsils. If you can take a look, if in doubt, please go to your pediatrician, give them a call. And it is problematic when kids are on antibiotics for a long time, because then the antibiotic is also killing some of the normal bacteria of the body. So we prefer to treat a child for strep and eradicate it so that they don't get it back. In rare cases, children with repeat strep may have to have their tonsils out, but we don't do that as often as we used to. Thank you for that. All the questions are fabulous. Thank you. I guess there's one more. I see it. Homeopathic remedies to be useful in helping our children stay healthy. So there are homeopathic remedies, various teas, various brews, various nutritional products, dietary products. And there is an entire branch of the NIH that looks at what's called alternative and complementary medicines. And many of these have gone into clinical trials to see if you randomize children and treat them with homeopathic on this side versus standard of care on that side, do they do better with homeopathy? And in general, they do worse, I hate to say. Western medicine seems to do better than homeopathy. Now, the important thing with homeopathy is to see if it might do harm. And the internet is not the greatest source because you have people pushing certain products, people who have vested interests. So if you can go to a legitimate site like the alternative and complementary medicine site of the NIH, you can actually see what the evidence is for or against a homeopathic product. And sometimes homeopathic products can be soothing and harmless. People use honey to be soothing and harmless in a little bit of tea. You know, for older children, that might be very, very helpful. And that can be seen as homeopathic and natural. And maybe it doesn't cure them, but it might soothe some of their symptoms. So I'm not hostile to homeopathic medicines, but I do like to research them and find out what the strength of evidence is to support them. There have been some unsafe homeopathic products that have been promulgated, and of course, we want to avoid those. All right. I think we're going to get you to dinner a little early. Maybe, Chloe-Ann, can you take over and close us out?
Of course, I would be happy to. First of all, I really appreciate you two coming to our webinar and presenting to our families this evening. The information was very, very helpful and very informative. Before I do close out, I just want to let everyone know that we do want our students to come to school, because school is better with them, even when they're a little under the weather. So we urge our families to, if their students complain of not feeling well that day, if they're just having a runny nose or a little cough, but they have no other symptoms, they are good to go to school. If they haven't had any fever reducing medicines for 24 hours and they don't have a fever at the time, they can go to school. If they haven't thrown up or have had any diarrhea for 24 hours, they can go to school. So we don't want kids coming to school sick, but we know that often students may not feel too well in the morning, but we would like them to come to school and be able to receive their education for the day. And I'm happy to send a flyer out to families with these types of guidelines. So with that, I want to also invite everyone to please come to part 3 of our 3-part webinar entitled Protecting Our Youth, A Community Approach to Suicide Prevention. You can scan the QR code or register for this on the link. Each link in each QR code is unique to each part of this series. So even though you were registered for maybe part 1 and part 2, you would still need to register for part 3. So again, we appreciate your attendance and staying with us tonight. Thank you, Dr. Vermond and Dr. Bro, for being with us tonight, and we hope you all have a great night. Thank you.
Bye-bye.